to really come to public health, and we're really trying to protect everybody's health.
No, just briefly, Zara, it's the same call I made last week, that it's really important that people who are contacts, I mean, Dr. Maddox has given you an example in meat plants, but I make the same call generally. As people are contacts, it's really important they come forward for testing, and vast majority of cases do. But as you've said yourself, there's 4 times more likely if you're a contact than you weren't a contact of testing positive. So we make that general call across the board for people to come forward for the appointments. We're booking an appointment for them. They don't need to go to a GP, and that helps us follow and track this disease.
Just wait for the microphone, Zara.
I suppose surely people who are living in the community where this meat factory is, though, would probably like to know that there might be a potential outbreak in their community and to be more vigilant, do you think? I mean, if you've got a meat factory where there's a lot of close contacts who haven't been contacted, is that not concerning, do you think, for that community?
I think just briefly, as we head into next week, I'd make that call to everybody about being vigilant. We all have to work and operate in a society to know that the disease is out there, keeping the social distancing that's there. If you're feeling unwell, go to a GP immediately, go for referral. So I'd make the plea in general that it's important, no matter where you are in the country, no matter where they've had lower outbreaks, it's really important we keep our diligence, specifically next week as well.
Do you want to come back in there, May?
Just to add, I suppose, a point, we are notified of all cases, so we would notice if we were getting, cases from the vicinity, if you know what I mean. Not that I'm aware of, but I'd need to check that because in that particular facility, but no, not that I'm aware of.
There's a language barrier sometimes with the calls and stuff. Is that what's sort of delaying the contact tracing in the community, or is it what is the key issue here?
No, it's not that really, because we have good access to interpreters, and that it's because there's a digit wrong in the number, there's a reluctance to answer the phone, that kind of thing, really.
Okay, Casey.
Paul, for yourself.
Just introduce yourself.
Sorry, Casey Reardon, News Talk. You said the data commissioners told you that data breaches didn't occur and that legal advice supported that. But are you worried that it will damage the uptake of the app, that you kind of went to great lengths to explain the precautions you're taking? And when do you envision this app being up and running? Because it has kind of been in the works for quite a while.
If I can take the 2 things separately, just in terms of the potential breaches, as you just heard from Dr. Maddox there, the way in which our public health teams manage outbreaks is quite diligent. Confidentiality is key, and that's the first big driver for them. And there are exceptional cases where they may need to inform an employer, and I think you just got a case example there how that might happen, and that's the way we want to do it. We want to make sure that that's done consistently, nationally in the same way, and we're developing standard operation procedure to make sure that happened. That's what I said on the day when this broke. That's those rare exceptional cases where it is facilitated under legislation, under sections within the GDPR legislation, and that's what they comply with. So the reassurance that we got from the Data Commissioner was that a breach didn't occur when we were able to walk through the examples how that had to manage. Specifically in relation to the contact tracing app, we'll be putting a lot of communications behind this once we go to launch. Just to say to you in terms of the timescale of the development of this, there are not too many countries across Europe or elsewhere who have rolled out significantly in terms of the app. So there is technical issues you have to manage between the interface between Google and Apple, and that's what we've been working through. As the confidentiality piece, just to reassure the public about it, the data is not held on the central health systems. It is in some countries. In ours, it'll be held on the person's phone and distributed out through the app. So the data is not held centrally and can't be used centrally. And that's the communications we'll be putting in as we go to launch the app.
Do you have a date that you hope it will be launched? Or?
We're expecting to go to government for approval in June, and we would like to go immediately after that.
Okay. Orla, you're trying to come in there?
Orla Ryan from the journal.ie. Phase 2 is due to kick in next week, and there's been some talk of restrictions being eased earlier than originally planned. Are you concerned that there could be a second wave if restrictions are eased too quickly? And in relation to schools, do you expect or hope to see trial runs of schools reopening perhaps for a week in the summer so that schools are ready in September, or could that date be pushed further back so some schools might not open till October, November? And just one follow-up on the contact tracing app. A Sunday Business Post poll last weekend said about 57% of people said they would use the contact tracing app. Would you be happy with that rate, or would you like to see a higher rate in order for the app to be successful?
We just give the public health measures to you, Colin, firstly.
First of all, we're moving to phase 2 because we now have a confidence as a country that we can move to phase 2. You've heard some of the figures there, less than 400 new cases the past week. It's easy to forget that in the middle of April we had over 4,000 cases in a week. We also heard hospital numbers down to 140 from a peak of 879. And the positivity rate of the testing, the volume of testing has gone down because of the reduced number of people referred for testing because of, again, fewer cases out there, only 1.7%. So these measures and that R value we all know about now give us the confidence to move into phase 2. But each phase, as articulated, involves monitoring those key metrics. Are our hospitals under pressure? Is community transmission suppressed as much as it can be? And we have to be assured as a country that we're keeping the virus under control, if not effectively extinguished, as it's almost completely extinguished within our society at the moment. We have to make sure we keep it at that level as we progress from phase to phase. So any decision made by government or by an effort will have to bear in mind is off its time and will have to be based on the assurance that the virus as an agent of transmission out there in society is as extinguished as it can be. The second question about schools, as I understand it, yeah. Well, my understanding is, as yours is, that it's opening, that they're due to open September, and how that's operationalised and managed is a matter for the Department of Education on consultation, obviously, with and advice in public health. We can draw some experience. One of the advantages we have in this country is because our experience with the virus is a little bit later than other European countries. We are now watching their experience as they open up schools, and the amount of information we have about the virus, how it's transmitted, what populations are particularly vulnerable, is so much greater than it was even a couple of months ago. So in Denmark, we know the reopened schools. We have those figures I just mentioned, those measurements, hospitals, ITU, new cases haven't risen dramatically. Of course, one of the issues with children is they're not tested as much as other people by virtue of the fact that they rarely present with symptoms and haven't been prominent in terms of close contacts. But still, it's critically important to all of us that we don't see outbreaks emerge in any congregated settings, be it healthcare, be it education, and elsewhere. So, in terms of how these public health advice emanating from NEFIT is operationalised, that would be a matter for the Department of Education and schools. But as my understanding is that's due to progress in September. There's no pilot schemes arranged, to my knowledge, in intervening period.
Okay, Paul, the 57% uptake on the app.
Yeah, just briefly on the app, on the uptake as well. I mean, just to say, firstly, our major operation on contact testing and tracing is the operation that we have in place, whether it's through our lab testing and our contact tracing teams. That's the significant operation. The app we have always seen as a further enabler, right, but not the major operation. The uptake that we would see, and this is ranged in experiences across Europe, there's a range that says somewhere between 60 and 80% would be ideal uptake that you would get to give you a huge benefit. And so, we welcome that poll that said 57% or whatever. So it does seem to be in the range of about 60% or upwards, gives you the better real feedback in terms of the use of the app. Just the Irish public have been quite adaptable to mobile technology over the years. Our uptake on use of apps and our uptake of use of smartphones is quite strong. So, we'd be hopeful to get a major uptake, and we'd put in a lot of communications behind it. But again, I would just put it, our major operation on testing and tracing is the operation itself, not just the app.
Okay, Sinead.
Sinead Crowley, RTE. Paul, can I ask you to go back to the testing again? You had mentioned the turnaround times that were good, but that there were some outliers. Could you give us a bit more information about that, please? And also, are there any plans to use the additional capacity that is clearly there?
Yeah, so on the first one, I described our mean time, which is the point at which most people get their test result. Last week is at 2 days. So most people get their result within 2 days, and that's across hospital and community. So obviously quicker in hospitals. In fact, it can be less than 1 day in terms of hospital. And the mean time is the end time from referral all the way through to contact tracing completed. However, the second measure then is that we had set out for ourselves was 90% of all contact tracing to be completed end to end by 3 days. We're at 82% for last week, so not at 90%. Some of the outliers can be some of the more complex cases that we just described earlier on in terms of congregated settings. But what we are seeing is if a person has come from, say, a GP referral, we're at about 85–86% of those being done within 3 days. The more complex ones are the outliers that can pull us back. And indeed, there are some that just fall off through the process in terms of there are still some not automated processes we're working through, and some outliers can just fall off. There are a couple of others I just would say that would be outliers where if we are testing in a dedicated centre and the local community teams may set the appointment, so today is Friday, they may set it for next Tuesday to be done. So you're seeing a lag time there in referral, and that's something we want to work through in terms of how we make the appointments relevant. So some outliers can just be ones that fall off, some can be more complex cases, and some can be due to delayed appointments made.
In relation to, is there any plans for using the capacity that is
Oh yeah,
necessary?
apologies. In our capacity, so we're at currently, as I mentioned last week, we've been hovering between 25 and 30,000, have capacity for 100,000. Decision from recommendation from NEFIT yesterday, there's two aspects. Our testing strategy is still being worked through where we might go next, but there has been a decision from NEFIT yesterday, which is we'll work through over the next couple of weeks a plan to test healthcare workers on a weekly basis over a 4-week basis in nursing homes, and we'll assess the impact of that or the benefit of that after that. But we do plan to look at a strategy, particularly for healthcare workers in certain settings.
Colin, do you want to come in there?
Just to elaborate, yeah, there is, as Paul said, a testing strategy devised by Lorraine Doherty, our Clinical Director of Health Protection, and that's the purpose of the testing strategy is to see how we can most usefully apply the resource we have in terms of breaking the chain of transmission of the disease. So there will be a particular focus on healthcare workers in certain settings, as Paul mentioned, residential care facilities being one. Again, it's important to remind ourselves that testing is a point in time. It tells you information on that day. It doesn't tell you information about what happens the following day. So it's part of it. It informs rather than is core to the control measures that are necessary, that are put in place by my colleagues, such as Dr. Mannix here, in terms of those public health measures which break down and beat down the disease in our community. So it's an important enabler rather than the core function itself.
Okay. Don't see any other hands. Okay, on. Just wait for the microphone now.
Owen Conlon from the Irish Sun. Professor Paul Moyna from Maynooth University was on Morning Ireland this morning, and he said that he felt Ireland had been on the slow side and ultra cautious in reopening the country. And he also said that he felt when he looked at the data, there is no strong evidence to suggest the full lockdown that was imposed was effective from March 28th, that the benefits accrued were from restrictions that were put in place before that. Would you agree with that or disagree?
Colin.
I didn't hear the interview, first of all. In strictest terms, interpreting that, there were packages. These were public health measures that were introduced, social distancing. There was a package of measures, and you remember yourself back to March the 12th when schools were closed, and then March the 28th, there were much more stringent measures brought in. While it's impossible in the strictest sense of the word to link any one measure with what has happened, what we have seen is a collapse in community transmission. We have seen cases go down from over 4,000 per week to just under 400 per week. We have seen positivity rates of testing go down from 25% of all tested to now 1.7%. We have seen numbers in ITU drop by almost 80%. So I have no doubt in my mind, not based on the absolute, if you're setting a target of absolute proof, I can't link any one of those measures to what's happened, but I have no doubt that the measures that were brought in and people's compliance with those measures have led to the collapse of community transmission from a situation where we were perilously close to widespread, uncontrolled community transmission and an overrun hospital system, such as we saw in other countries. And I have no doubt that if those measures hadn't been brought in, we would have faced the same fate as other countries that did face that appalling scenario.
There was mention there in relation to Denmark and how the schools have reopened there and how we're keeping an eye on things there. Has there been any other data from other European countries that has proven useful in terms of monitoring their experiences as to how we can benefit?
That's a good question because, again, going back to the interview you said this morning, we're at least benefiting on some data from the end of March to show what's happened. But now we're looking at countries reopening, and they're doing that almost in real time in front of us now. And so at the moment, we're relying on the lowest form of evidence, which is just experience as they begin to reopen. We see reports of outbreaks in Spain. There was a report of an outbreak at a house party with numbers of cases. But how that will translate into those big figures that really, really inform us as a society, as a people, as a government, as to what we should do, that will be the numbers of new cases, the numbers coming into hospitals, the numbers coming into intensive care units. They're the big figures that actually give us information as to how effective our social distancing measures are and how safe our loosening of those social restriction measures have been in terms of the measures, first of all, and secondly, in terms of how people comply with them. So we can only draw, to answer your question, on anecdote and experience at this point in time. But as time goes on, we will have the benefit of having more advanced knowledge based on the fact that other European countries who've gone through this whole narrative a wee bit earlier than us, we can see how the effect of their loosening of social measures have been on the numbers of new cases and those critical measures I've just mentioned.
So just to clarify, I mean, obviously publicans are calling for them to be allowed open sooner. Presumably as part of that, you're watching bars in Spain and seeing what potential impact their reopening has on infection levels there.
Well, the message was stay at home, and now it's going to be stay local. And what we can say is it's not over. The virus is still out there. If you look at the number of new cases I just mentioned, less than 400 per week, we know some of those cases are unexplained in terms of their link with another case, or in terms of outbreak that some of those cases are not explained, meaning it's out there, albeit at a very low level. But as long as it's out there, even at a low level, there's a danger of transmission. There's a danger of each of those cases leading to a further outbreak. If one of those cases that isn't linked to an outbreak that May is managing, but isn't linked to another case, in other words, a pure case of community transmission, goes into a crowded bar in Dublin, that case, we know this is a very transmissible virus. That case, before they develop symptoms, will transmit the virus at a very high level to other people in that bar. Each of those people in turn will transmit the virus to an equal number of people at an R value, and you remember that R value, which is much higher than what it is now, at 0.6 based on suppression measures. But the R value, and May can correct me, this in crowded environments is much higher.
Okay. Evelyn, just wait for the microphone and introduce yourself as well at the hall.
My name is Evelyn Ring. I'm a reporter with the Irish Examiner. It's just an observation I had during the week. I was in 2 supermarkets and the alcohol gel was empty in both places, and I thought, well, that's a bit odd, like, for me to find it like that. Is there a legal obligation for retail units to have the alcohol gel available for customers?
Good question. I'd ask May. It's advice. What happens is, just to give the line of governance or responsibility here, the advice is given. It's not binding. We would expect, and we in the HSE, because we want to protect our hospitals, we want fewer patients coming in sick, we don't want outbreaks. We expect people, whether they're supermarkets or shops or coffee shops, to comply with the advice given, because and that includes the distancing, it includes avoiding queuing, avoids congregation, and includes placing facilities for people who are going to that shop in order to make sure that they can keep clean hands. But I wouldn't want to take away from equally, if not more important messaging, which is the distancing is important in such facilities, that there's no congregation of people in a way that would allow the virus to transmit. As for their responsibility in keeping the gel, that's entirely up to them, but I would hope that each facility would do its part, as there have been since as we gradually reopen society, to keep people safely apart, and also to provide people whatever facilities or gel or whatever it is they need to keep clean, their hands clean, and to avoid transmission of the virus.
Evelyn, is that you? Yep. Sinead, in Kester son Reading na Gaeltachta no TG Carr.
Son Martin Beidir just an rudsin VRO got obviously a new an law more a tomagic sul gamor le ruddy of any osculta and tachtan hugging, but on core gamertini fos kuramach or horda agus it's a groupie more.
Well, higling our sheernish 3 ta hart on kid cas in agin in airing agus tanakid dulcon kin chod Greek agin no hinale. Tamid gawach figuri awadnis isha nach redmid gnamshin the major nocher urig chak the shafagur and the hospital done nishle the major nocher igdol figurum none gerhurmake done nishle agus the made the gas the ure ig kitchen niwan shachten gele ach olager gele ach ta is like in go gala inter togalach ta an ta inter forest a halgu digentet so agus nilen skiel shin igemacht tan virus and we sa phobal fos os go fader sa tasha we sa phobal ta buelaun go me ragan ag brishu mach a shahamach so kamen we interkurmach ni higlig an mar dercher and magic lishra agus kamen klieg docht dangen lis de multi der erma tashid lagashias o derni varte ele
Margaret. Any? Paul, yeah, good question.
Paul Cullen, Irish Times. 2 questions. Firstly, on the meat factories, I was just wondering if any issues relating to the status of some of the workers in Ireland vis-à-vis work permits or immigration is a factor in the difficulties in contacting people. Has that arisen in any case? And secondly is about trolleys. We thought we did say goodbye to trolleys for a few weeks, but they're back now. And can you give guarantees to people who have to go to emergency departments that they will be safe in those emergency departments where already we're seeing large numbers of trolleys appearing once more?
Okay, we'll start May. Do you want to pick up the meat factory one?
Yes, so the question is around the issue of permits and whether that's a problem in terms of contacting. I think that was what you mentioned, Paul. I suppose there's a couple of issues there. One is the whole language issue, which is one thing we've tried very hard to address in terms of having the materials available in different languages and having interpreters available and that kind of thing. We've also encouraged, I suppose, the employers to ensure that the employees know that if they do have to go off work for a COVID-related illness, that they are entitled to the COVID payments and what their entitlements are. Other than that, I don't know if there's any other issue that I can speak to on that point.
Okay. Anne, do you want to come in on the...
I think so. In terms of trolleys, Paul, you're right there. We're still seeing trolleys on trolley gar. What I would say, though, is that there's a couple of points to make. One is that, you know, obviously we'd love to guarantee safety all the time, and we can't do that, clearly, so we have to look at what we're doing to mitigate against the risks that may be there. For people who are presenting now, there are different pathways. So if you attend an emergency department, there's a COVID and a non-COVID pathway. If you look at Galway, for example, they have, you know, you go through a kind of a porta-cabin and you're determined as to which pathway you should be in and all of that. I think when we see, and it's a discussion we're having ourselves in terms of the counting, the famous counting challenge, but trolleys now are not necessarily trolleys lined along a corridor. They're, if you look at some ED departments like Limerick, their ED is single isolation rooms. So technically they're trolleys, but they're in single isolation spaces, and they are there because it is deemed to be a safer place because they have the capacity to isolate. So for us it is building on, I suppose, a way of working that allows patient flow in a safe manner through the emergency departments, using isolation areas appropriately. And, you know, for us that does raise the question of what are we counting and how are we counting it now, because we are moving people in different ways through our emergency departments because of COVID. So clearly we are doing everything we can to ensure that we reduce any risk to staff and patients. But you know, it's definitely challenging. But today we have COVID and non-COVID pathways to keep that gap between people who may be infected.
Colin, do you want to add to that? No? Okay. That's you, Paul?
Sorry. So what is an isolation space? Is that something with ticker tape around marking 2 metres?
No, they're actually rooms. So if you look in Limerick ED, it's actually, they're kind of like proper room cubicles. They're not curtains or anything. So you have a door. So you're on a trolley in a space that is kind of walled with a door. So that you will be put into a nice... So they keep their ED actually for the COVID pathway throughout this. They have done that, and they have kept their non-COVID patients going in a different way. So they haven't used their traditional ED space for non-COVID. They've kept that for... So what the point I'm making is that sites themselves have determined a COVID and a non-COVID pathway, and they are using whatever space they have to best effect to ensure that infection is managed and that people aren't cross-contaminated in any way.
What would you do if the number of trolleys continues to increase?
So there's two things.
Kind of numbers we saw at the start of the year,
so I
or anywhere near that.
Yeah, I think there's two things. So trolleys, as we know, are just a symptom. Trolleys on their own don't mean a whole lot. What is important to us is the flow of patients from the front door right through. And critically for us, what we've been focusing on, and something that we've been doing for the last couple of winters, as you'll be aware, is the whole admission avoidance piece. So how do we reduce the need for people to attend for ED in the first place? As I said earlier on, a particular focus for us would relate to older people and people aged over 75. There are other pathways that we need to develop, so we know what they are in a sense in terms of keeping people at home more, supporting GPs more. So we're looking at that as part of the continuity work, and there are initiatives that we have already started developing on foot of the learning from the last 2 winters around that. When you look at, you know, the integrated care programme for older persons, fit teams in EDs to ensure older people don't come in and don't stay there. I think the other thing we have to look at is how we actually use our space safely. You know, we can't have a position where we have corridors full of people and, you know, a mixing of people who may have COVID or not. That's just not part of any way that we're thinking about the future. I think what we know, and Colin and I are co-chairing a group that's looking at service continuity, what we know is that service delivery will look and feel different. We are doing a lot of work across all of our services, working with clinicians and the service managers to say, right, how do we deliver our services in a way that will keep people safe, not have what we have experienced. I mean, clearly, we can't guarantee anything. So we can't sit here today and say we will have no trolleys because we don't know what pathway this disease is going to take as we approach winter. We really hope that the measures we've taken will continue to keep those numbers low and all of that. But really, it's about trying to keep people out altogether. So our challenge is to keep as many people away. That's not to say that we wouldn't be providing services, because clearly where people are very sick and need urgent or emergency care, they do need to attend. But we have our minor injury units and we have other pathways as well.
Just bring Paul in and say
I just want to add one extra point to what Anne said, because just acknowledge our winter plan for this coming year will have to be very different than our winter plan of the previous couple of years, because we're living with COVID. And as Anne said, we'll look at some of the traditional ways of keeping people out, but we will also need more capacity for the coming period. And part of that will be whatever we can negotiate through with private hospital groups. That has to be part of our solution for winter. That will be what we are talking with the department and talking with government about. The winter plan ahead has to be very different, and will have to give us extra capacity through whatever means we can secure it.
Okay. Are we at an end? Anybody, any final questions? No? Okay, listen, thanks very much for coming. Once again, thanks to DCU for hosting us, and to Professor McCrath. Very good to be here. Thank you for joining us from home, and we'll do something similar next week.